Good afternoon. I'm Dr. Phoebe Thorpe, and it's my pleasure to welcome you to CDC Public Health Grand Rounds for March 2019, Suicidal Behavior in American Indian, and Alaska Native Communities, a Health Equity Issue. This is an important and informative session, so let's get started. First, a few housekeeping slides. Public Health Grand Rounds has continuing education available for physicians, nurses, pharmacists, veterinarians, health educators, and others. The course code is PHGR10. Please see our website for additional information. Talking about suicide can be difficult, but there are lots of tools to help. We have additional resources listed at the end of this presentation, but we felt it was important to include this number early. New guidelines were recently released about how best to portray suicide in TV shows and in the media. These will help shift the national dialogue. At the individual level, some are afraid to talk about suicide, leading to a silence that surrounds it and perhaps a lack of understanding of why individuals thinking about suicide have difficulty asking for help. One of the cruel tricks of deep sadness and depression is the loss of interest in friends and activities. I'm told they are not as much fun as they used to be. This withdrawal can lead to isolation and a cycle of deepening sadness, withdrawal, and more isolation. We can break this silence. This is a national hotline number that anyone can call to help prevent a suicide. Grand Rounds is available on the web and on your social media sites. Please send questions for today's session to grandrounds@cdc.gov, and we'll try to include your questions in the Q&A today. Want to know more? We have a featured video segment on YouTube and our website called Beyond the Data, which is posted after the session. This month's segment, it features my interview with Dr. Spiro Manson. We also have partnered with the CDC Public Health Library to feature scientific articles about this session. The full listing is available at cdc.gov/scienceclips. Here is a preview of our upcoming topics. Please join us live or on the web at your convenience. In addition to our outstanding speakers, I'd also like to acknowledge the important contributions of individuals listed here. Thank you. And now for a few words from CDC's Deputy Director, Dr. Ann Schuchat.
Well, thanks, Phoebe, and thank you all for being here, and thank you to our speakers for traveling in. Welcome to today's Public Health Grand Rounds. Suicide is a difficult issue affecting too many individuals, their families, and their surrounding communities. Increasing insights into factors that influence risk for, as well as protection against, suicidal behavior are providing greater opportunities to tackle this public health concern. Last June, through a Vital Signs release, CDC reported on surveillance data for suicide, which found that since 1999, suicide rates had increased more than 30% in half of the states in the country. The report also found that more than half of people who died by suicide had no recognized mental health condition. Many preceding situational stresses were common among people who committed suicide. CDC has synthesized the evidence base on prevention of suicide in a technical package of policy, programs, and practices, which you'll hear more about today. Today's Grand Rounds will review recent epidemiological data, including recent trends. The presentations focus on one of the hardest hit population groups, American Indians and Alaska Native communities. While factors contributing to recent trends may differ across communities, effective strategies that can make a difference can be adapted to appropriate cultural contexts. Our presenters will describe interventions targeted for school children, primary health care, and occupational settings. Today, you'll also learn about resources for public health, clinicians, and members of the public. Whether you live and work with American Indian and Alaska Native people, or in other settings, whether you are focused on health of young people or older populations, you should gain insight into strategies that can contribute to resilience and inoculate communities against suicidal behavior. CDC's director, Dr. Redfield, reminds us frequently that stigma is the enemy of public health. Today's Public Health Grand Rounds helps us advance the agency's work on prevention of suicidal behavior, and I hope will empower each of you to make a difference in your own communities. Thank you.
Thank you, Dr. Schuckett. And now for our first speaker, Dr. Alex Crosby.
Well, good afternoon to all of you. Thank you for coming. And I wanted to thank the Office of Minority Health and Health Equity for organizing this Grand Rounds and also for the invitation to come and to talk with you today. What I'll deal with is understanding suicide in American Indian and Alaskan Native youths. As why this is an important issue is we've noted for the first time, the National Center for Health Statistics noted that life expectancy in the United States decreased for 3 consecutive years. This is almost unprecedented. The last time that they saw 2 consecutive years was over 50 years ago. And one of the leading causes as to why life expectancy is going down has to do with the increasing suicide rates across the country. So it's important for us to understand this problem, try to figure out what we can do about it so that we can reverse those trends. What I'll do today is I'll talk about describing the patterns of suicidal behavior among American Indian and Alaskan Native populations. I'll give a little bit about discussing the risk and protective factors for those particular populations. And then lastly, give some information about the evidence-based or the best available evidence that we have in regards to programs and policies for dealing with this particular problem. One of the things that we know about suicidal behavior is looking at the most recent data that we've got the full United States for, which is 2017. Suicide was the 10th leading cause of death during that year. Over 47,000 deaths occurred in the United States. That's an average of about a suicide every 11 or 12 minutes in the United States. And while it's the 10th leading cause of death overall, you can see that it disproportionately affects certain populations. And you can look kind of in the middle of this slide and look at non-Hispanic American Indian and Alaskan Natives, that suicide is the 8th leading cause of death in that population. So from 10th overall to 8th among this particular population. Another way that you can also try to look at the measure of the magnitude of this particular problem is which age groups within those populations seem to be affected. You can see in the gold line that suicidal behavior, especially deaths due to suicide, really impact young adult and adolescent American Indian and Alaskan Natives, especially that 15 to 34-year-old age group. And you can see that in other populations, other racial and ethnic groups, it affects different kinds of populations. Among non-Hispanic whites, it tends to affect middle-aged adults, those in their 40s and 50s. So different populations affecting different kinds of age groups. Suicides really only measure one portion of the burden of suicidal behavior in our population. This pyramid tries to illustrate how this problem affects not just those that die as a result of suicide, but also non-fatal injuries and also those who self-report. You can see at the top of the pyramid that looking at 18 to 25-year-old American Indian and Alaskan Natives in 2016, that there were 151 deaths. Looking at those that were hospitalized due to more severe suicide attempts, 340. Those who report on surveys that they've made a suicide attempt in the past 12 months, about 2,000. And then those that say that they've seriously considered suicide in the past 12 months, over 12,000. And there in the parentheses, you can see the ratio. So for every 1 death, about 2 hospitalizations, 13 suicide attempts, and over 80 persons that say that they had seriously considered suicide in the past 12 months. So the burden becomes even bigger. And we know that those that have attempted suicide are at the greatest risk of subsequently dying as a result of suicide. Suicide rates, as you heard from Dr. Schuckett, have been increasing in the United States over the past 10 to 15 years. One of the things to see here is pointing at that gold line again, is in most recent years, those rates among American Indian and Alaskan Natives have increased even faster than some of the other racial and ethnic groups. We also know something about the risk and protective factors in various groups and specifically among American Indian and Alaskan Natives. One way of looking at this problem is looking at the socio-ecological model. And I'll talk about some of the different factors in this model and not try to go through all of them here. But one of the ways that this model tries to identify risk and protective factors is at certain levels, at the individual level, at the family and peer level, at the community level, and at the societal level. And I'll talk about a little bit of those. At the individual level, you can see age and sex are different. And when we look at age, just as I talked about, adolescents and young adults among American Indians, Alaska Natives, males die as a result of suicide at much higher rates, about 4 times higher than females. But when you look at non-fatal injuries, females attempt and report more non-fatal suicidal behavior than males do. Looking at the examples within the family and peer and neighborhood level, identifying and assisting persons at risk is one of the protective factors within that particular group. We also know that a risk factor is a family history of interpersonal or self-directed violence. If there's been someone in the family that has died as a result of suicide or has attempted suicide, that puts other members of that family at greater risk. At the community level, spirituality is a protective factor, and then reducing social isolation is also a protective factor, including something that we call connectedness. How can you make sure that a person has a strong social network of friends and family? That's a protective factor. Looking at examples at the societal level, reducing access to lethal means is a protective factor. Intergenerational trauma, which is something that has occurred in many American Indian and Alaska Native communities, the loss of land, the inability to practice religion, inability to use the language, having children that have been taken away and put in boarding schools, all introduced trauma into those communities and increased the risk for suicidal behavior. Another way of trying to look at the risk and protective factors is a framework that was developed by the World Health Organization, looking at the social determinants of health. And I won't go through all of this, but looking down at the bottom, they're the structural determinants of health inequities, and then also the intermediate determinants of health. The one that we'll try to focus on a little bit today is at that socioeconomic position, especially looking at occupation as one of the social determinants of health that might be influencing suicidal behavior among American Indian and Alaska Native communities. In response to what we saw was going on in suicide and the increasing suicide rates, the Division of Violence Prevention developed a technical package that did a systematic review of evidence-based programs and policies to try to identify those that had been successful and had a good track record of what they were doing in making sure that there was a strong, rigorous evidence base. We looked at it for suicide prevention, for child abuse and neglect, for sexual violence, youth violence, and intimate partner violence. We identified 7 different strategies in regards to suicide prevention, and the ones that you can see highlighted are those approaches in which we'll talk about them directly or indirectly in regards to some of the other presentations today. Those 7 different strategies identified were strengthening economic supports, strengthening access and delivery of suicide care, creating protective environments, promoting connectedness, teaching coping and problem-solving skills, and identifying and supporting people at risk, and then lessening harms and preventing future risk. In conclusion, some of the things that were important about understanding the problem of suicide among American Indians, Alaska Natives, is that suicidal behavior disproportionately affects American Indian and Alaska Native populations, especially youths aged 15 to 34 years of age. A comprehensive approach is needed in order to reduce this serious health problem. One of the things we found when we developed that technical package is that communities that used more than one strategy were oftentimes the one that were more successful in reducing suicide prevention than those that just tried to use just one. Suicide prevention strategies should include culturally appropriate services and programs, and you'll hear a little bit more about that in the next presentations. And then together, we can reduce this health equity, that it really does take a collaboration and partnership at the community level in order to really make a difference. Next will be Dr. Teresa Laframboise that will talk about some of the specific strategies that try to address suicidal behavior among American Indians and Alaska Native youth.
Thank you very much, Alex. This is a wonderful opportunity to be able to talk about school-based suicide prevention with Native youth. So let me begin. Schools are second to families in the potential impact that they have on children's mental health. Ideally, schools are places for the healthy development of children. Not only are we imparting knowledge and learning, but also providing nurturance and opportunities for children to build good, healthy, respectful interpersonal relations. Now, I know that sounds ideal, but certainly schools are the place where we can instill a sense of belongingness and connectedness that Alex referred to as a very important protective factor for suicide. School-based mental suicide prevention really began in around the 1984 or so, and as a result of the escalating suicidal behavior among adolescents in Western industrialized nations. Towards the end of the 80s, I was invited by the Pueblo of Zuni to develop a suicide prevention intervention because there had been deaths. There had been 5 deaths in the high school, and this was a relatively small community at that time with a population of 7,000. Over the period of 3 years, we developed and evaluated an intervention that was focused in a large part on social cognitive theory, with the idea that a behavior is really influenced by modeling and direct learning, as well as individual characteristics, and as a person mediates decisions about risk behavior. There's a Pueblo there. Okay. Social cognitive theory is the basis of many interventions in social and behavioral skills training, classroom-based curriculum to prevent substance abuse, aggressive behavior, risky sexual behavior, and the prevention of depression. And given its influence on modeling and the fact that there is so much suicide in many communities, it seemed to be an appropriate theoretical approach. In addition to that theory, we also look at stress coping model. As in a way, this is our logic model for the curriculum development. But as you can see in this figure, I've enumerated a number of risk factors, many of them historical, but this could be a backdrop, as you know, in the field of suicide prevention of other risk factors. But this is what I've selected for the image. But thinking of ecological factors in the air, such as historical trauma or intergenerational trauma, pervasive poverty, acculturation, stress, and then it goes on down. But so let's say that there is a backdrop of risk factors. And according to the stress coping model, a stressful event happens. People choose to either avoid the situation and use avoidant coping or approach coping. In the work that we've done, we seem to see a pretty rampant pattern of avoidant coping where a person who has a stressful event, I'm talking about American Indian Alaska Native youth, often self-medicate, self-isolate, and eventually engage in suicidal behavior. Interventions such as American Indian life skills try to encourage approach coping, taking direct action, seeking social support, talking to others, monitoring emotional arousal, discussing problems, etc. And in some, we use in this curriculum primarily emphasizing effective problem solving and positive thinking with the idea that it would lead to resilient adaptation. This is a lot of words, and basically it's describing the different sections of American Indian life skills. I'm shifting now from Zuni life skills to American Indian life skills because over a period of time, then we worked with other communities, and it became more inclusive in terms of the different tribes. But basically what I want you to see here is that through the course of some 44 lessons over a period of time, people move from learning the various skills, like understanding emotions and stress and communicating, problem solving, etc., to suicide prevention. It was a major lesson learned that we couldn't address suicide prevention at the onset. We had to gradually work up to it. And then we didn't want to bring students to that point and then leave them, and so we have several lessons at the end on individual and community goal setting. To put it more simply, I've just outlined here the core skills of the curriculum, but emphasizing across that with every one of these skills, we do address those through positive thinking and effective problem solving. And these, I guess you would consider active ingredients or mediating factors are present in a number of interventions for resilience. Okay. The first evaluation of the curriculum occurred with the Zuni community in the high school. In that situation, we were able we had intervention groups and comparison groups, and we found significant differences in those in the intervention group in hopelessness, their confidence to manage anger, their problem-solving skills, and their peer suicide intervention skills. In another study conducted by Dr. Phil May in a different reservation in New Mexico, they used the comprehensive approach that Alex is talking about, and American Indian Life Skills was included in that. But we cannot attribute these findings to American Indian Life Skills, but we can say that in addition to training natural helpers in neighborhoods and providing and screening and doing outreach in conventional and unconventional places within the community, that there was a strong impact. As you can see, when the intervention began in the late 80s, a big drop in suicidal attempts and suicidal gestures some 11 years later when this article was written. Another study is very interesting. This is one where, you say 44 lessons, how would I ever do it? We ask people, interventionists, to select the lessons that are most relevant to their students. But in this case, this community said you only have 10 lessons. We can get in the schools for 10 times. And so they conducted their own evaluation. And now this is not a comparison group, it's pre and post, but we did find decreased levels of hopelessness, decreased suicide risk, increased sense of public collective esteem, what students felt other groups think of their group, and increased self-efficacy and increased self-awareness. We've been asked many times when we think about the staggering rates of suicidal behavior now among preteens and even the behavior occurring with children, about the relevance of this curriculum with younger age groups. So in this effort, we conducted a number of classroom observations and had interventionists that are experienced in child trauma-focused care, look at the curriculum, and we decided that we needed to develop a simpler version. So we do have two versions going, but the middle school version focused on the kinds of problems that were more appropriate at early adolescence. It simplified the language, simplified the model, and was reduced down to just 35-minute lessons. There's only one evaluation of the middle school version, and hopefully someday we'll do another. But in this particular evaluation, we were able to go back to the Zuni Pueblo some 20 years later and evaluate the middle school version. We were only able to give the curriculum over a 6-week period of time, so it was heavy dosage every single day, 30 lessons. So the post-test was conducted at the very end of the curriculum. And we did see that there was a difference between the pre and post in tests with the intervention group, in which there were increases in self-efficacy to manage depression, efficacy to manage coping with stress, efficacy to enlist community support, and efficacy to enlist social resources. In conclusion, I guess what I would want you to think about this presentation is the fact that unfortunately schools are often overlooked as sites for suicide prevention. The emphasis is, of course, in healthcare settings, maybe correctional settings and emergency rooms, health facilities. But we've seen that school-based suicide prevention has shown many positive outcomes with American Indian Alaska Natives and also students across the country in an array of settings. American Indian Alaska Native youth have benefited from school-based suicide prevention. Hopefully you see that from what I've shared, at least in these small studies. And I think that what I want to say is that the trend now is to 2-generation studies and approaches to include families in this work and to do major community-wide change in suicide prevention is certainly increasing, but it's understudied. Thank you.
Ani Bonjour. I'm Spiro Manson. I'm on faculty at the University of Colorado Anschutz Medical Campus in Aurora, where I direct the Centers for American Indian and Alaska Native Health. My remarks today will cover 5 particular points. First, I will be emphasizing the conspiracy of silence that surrounds suicide and the discourse that characterizes that subject in Native communities and the consequences thereof. Secondly, I'll point out the importance of the primary care setting, as Dr. Laframboise did with respect to the schools, as a unique and timely opportunity for us to intervene, especially in the context of tribal healthcare systems in Native communities. Thirdly, I'll identify a particular evidence-based practice that has a well-founded history with respect to the detection and management of a series of problems in primary care that will serve us well with respect to intervening around suicide risk. Fourth, I will illustrate 3 exemplar programs across Indian country that have established this particular initiative with respect to detecting and managing behavioral health problems, suicide among them, among their patient populations, to illustrate that in fact such translations are possible, indeed desirable. And lastly, I'll end with a series of points regarding the challenges and opportunities that face us in the continued extension of this evidence-based practice into such settings as they relate to both improving the health of patients as well as enhancing the power of the systems that are available to deliver that care. So let's begin then with stigma and the nature of stigma. You know quite well here at CDC the power of stigma in terms of closing down the kinds of conversations that are absolutely essential to the discourse with respect to suicide and other kinds of conditions of this nature that contribute so much to the challenges that we face. In 1999, we concluded the largest psychiatric epidemiologic study in American Indian communities in the country. And in this particular study, we asked the study participants, over 3,000 of them, from 3 of the largest reservation-based tribal communities in the country, about their perceptions of the relative stigma surrounding a series of conditions. And this particular study underscored the fact that attempted suicide ranked only behind HIV/AIDS in terms of the power of stigma surrounding it and the consequences thereof. Now, in primary care settings, of course, I don't see anybody wearing a white coat here in the audience, but the power of the white coat in terms of the patient-provider relationship and what the power of that relationship does to encouraging in a nurturing and supporting manner conversations that are otherwise very difficult to have. And so, given the nature of delivery systems in Indian country, which are for the most part akin to health maintenance organizations in terms of the universal availability of that care and reducing, in many instances, the cost and other types of barriers, it makes a relatively potent opportunity for such intervention. SAMHSA nearly 20 years ago began to fund a series of initiatives focusing on detection and management of behavioral health problems in primary care. That evidence-based practice eventually became known as Screening, Brief Intervention, and Referral for Treatment, SBIRT, SBIRT. SBIRT is essentially a 2-step process in which an individual in the detection phase is identified at risk for the condition of concern, in this particular case, suicide. And then in the second step, is counseled with respect to a series of behavioral strategies that are designed to reduce that risk, as well as refer the individual to the necessary services that might assist them in dealing with and coping with that risk.
Indeed, it was in 2012 in the Surgeon General's report on the National Strategy for Suicide Prevention and Goals and Objectives that SBIRT was identified as a robust and potentially powerful intervention that might be extended beyond the prevention of substance abuse and alcoholism to suicide. Now, as I've noted, stigmatizing conditions such as suicidality are more readily discussed in these kinds of primary care settings, especially when it's done in a non-judgmental fashion. And as a part of this particular intervention, typically one co-locates a behavioral health consultant, again, consultant, not clinician, meant to underscore the destigmatizing nature of this particular feature of the intervention, and is assigned to the primary care team to work hand in glove with the various primary care providers there. What this does is that although it recognizes on the part of the primary care provider the risk that the individual is at with respect to suicide, it relieves him or her of the burden of having to intervene immediately and allows for a more pointed and extensive follow-up with that individual. It provides more time, and I needn't tell an audience like this about how little time there is presently available to providers in the process of care during clinical encounters. It's an opportunity to raise patients' awareness about suicide as a plausible concern. One of the major challenges is initially their recognition in that regard. It's an opportunity to enhance their readiness to change through motivational interviewing, enable the development of a patient contract between provider and patient about the next steps in this process of change. And it provides a very explicit structure for specific actions that can be taken in follow-up through referral and other forms of intervention in addressing those concerns. And our experience is that these elements of the SBIRT intervention are readily adaptable both to the patient organizational cultures in which we've worked. I want to briefly identify three specific examples and call them to your attention. We've published about them extensively. They're well represented in the literature. I won't go into the greater details, but encourage you to look at those publications. I think a series of citations were provided. The first is located on the Alaska Native Medical Center in Anchorage, Alaska. It's the medical home for over 65,000 Alaska Natives and American Indians living in Southcentral Alaska, in which those primary care teams now have co-located one behavioral health consultant, typically a master's level clinician, who's attached to each primary care provider team. They use the classic initial screening as an opportunity to detect, and then once detected, they call that to the attention of the primary care provider, who then activates and mobilizes the behavioral health consultant to follow up as appropriate. Since 2001, my colleagues there and I have screened nearly 58,000 unique patients. I think the particularly telling point here is that, in fact, not only were a substantial number of them deemed to be at risk for behavioral health problems, including suicide, but we were able to successfully triage them to the different levels of care that enabled them to address that risk. And indeed, this initiative was so successful after 3 years that the state of Alaska revised its CBT codes so that this SBIRT intervention is now fully sustained by the state of Alaska through Medicaid reimbursement. Second example is also located in Alaska in Fairbanks, in the Chief Andrew Isaac Health Center, the Tanana Chiefs Conference. Now we move into the interior of Alaska, which is a medical home for nearly 15,000 Alaska Natives and American Indians living in and around the confluence of the Yukon and Tanana rivers. There are a series, again, primary care teams there who have co-located a behavioral health consultant. They employ the very same kind of two-step detection and management process as does the Southcentral Foundation. And since 2012, we screened 11,000 unique patients there. Again, 26% of them were deemed at risk and followed up with appropriate referral, and it is now also sustained by State of Alaska Medicaid funding. The third example moves us out of Alaska into the Southwest and out of the rural context into the urban context. And specifically, the First Nations Community Healthsource in Albuquerque, New Mexico is the country's largest urban Indian health program. And you can see here the distinct features of this very large urban Indian health program. They too use this two-steps process. Since 2011, they've screened over 4,000 unique patients and have been certified and are now a full partner in the state of New Mexico's SBIRT initiative, which funds their entire effort. We face a series of challenges and opportunities, though, as we think about extending this particular intervention to other settings in Indian and Native communities. The challenges have to do with engaging eligible patients, minimizing the stigma surrounding that, and ensuring their confidentiality, maintaining the fidelity of how SBIRT is implemented within the clinical workflow and in the face of the multiple demands that providers experience. And lastly, ensuring patient transition through the process of care and maximizing their retention. Ultimately, with respect to the system of care, we face the challenge of documenting these services and linking them to the external resources beyond the program. Each of the three examples that I've shared with you today refer the individuals not only to biomedical resources, but also traditional healing resources that exist within their particular programs, as well as the ecology outside. Next systems issue is how to marry an intervention such as SBIRT with other kinds of intervention approaches to maximize the prevention gains, and ultimately to acquire rigorous evaluation data that we can use to document and support program and policy advocacy. So I think it's a bright example of how we can translate an evidence-based practice into these settings with good benefit to patients, providers, and programs. Thank you. Our next speaker is Mr. Michael Flynn, coordinator of the Occupational Health Equity Program at NIOSH. Michael.
Good afternoon. Thank you all for coming, and thanks to the Office of Minority Health and Health Equity for inviting me to speak today. I'll be providing an occupational health perspective on suicide among American Indian and Alaska Native youth, and we'll discuss the role of work in improving population health outcomes, including preventing suicide. As evidenced by the Surgeon General's call to action on community health and prosperity, there's growing recognition of the need for public health professionals to be conversant in the relationship between economic development and health. Given the elevated rates of unemployment and underemployment in American Indian and Alaska Native communities, which can reach up to 95% in some areas, improving access to good jobs is an essential piece to any comprehensive strategy for reducing suicide in these communities. Increased poverty has been associated with higher suicide rates in American Indian and Alaska Native communities. A recent study recorded significant decreases in psychiatric symptoms among a sample of Eastern Band Cherokee children aged 9 to 13, whose families had moved out of poverty after a casino was opened on a local reservation. Data analysis from the Behavior Risk Factor Surveillance System found that unemployed emerging adults aged 18 to 25 had 3 times greater odds of reporting depression than their counterparts who were employed. This is particularly salient given the extremely limited economic opportunities for American Indian and Alaska Native emerging adults, especially in rural areas. While these examples suggest that economic development and access to good jobs is an important piece of suicide prevention strategies, formative research on work-life balance among American Indian women in the Southwest and Upper Midwest reminds us that the definition of good job may vary by socioeconomic context. Many of these women reported additional stresses from having to balance their traditional roles as caregivers with their new responsibilities on their job. As you can see by the solid yellow line, unemployment rates for American Indian and Alaska Native youth are high, and rates remain higher throughout their lives than for any other racial or ethnic group. Conversely, the purple line shows unemployment rates for non-Hispanic whites and is highest for youth. However, suicide rates for this group are highest among middle-aged individuals. While we know that economic stability is protective for suicide, we do not have a nuanced understanding of the relationship between work and suicide across racial and ethnic groups. The variation in patterns of unemployment and suicide rates by race, ethnicity, and age suggests that more research is needed to better understand the relationship between work and suicide across these groups. What has long been recognized by socio-ecological models is that the influence of job, or lack thereof, on health goes beyond physical, emotional, and social conditions at work. Indeed, one's job or career exerts significant influence over other aspects of life that contribute or detract from an individual's health and that of their families, such as income, social status, housing, access to health care, and free time to socialize. As a result, work is seen as a principal mechanism for securing the needs to address health inequities. However, despite conceptual acknowledgement that work influences health through numerous pathways, it remains largely absent from examinations of health inequities in the United States. Despite common historical roots and social approaches to health, occupational health and the rest of public health has largely developed on parallel tracks. Today, the classification of work, non-work related exposures and outcomes often separates occupational health research and practice from the rest of public health. As a result, work-related variables are largely absent from health equity research, and the domain of work is underrepresented in public health practice. This current approach works well for identifying and controlling workplace hazards like exposures to asbestos, for example. However, it has limited our understanding on how work, or unemployment, impacts overall health and the inequitable distribution of health outcomes. For example, how might chronic unemployment contribute to the distribution of heart disease, substance abuse, or suicide among different racial and ethnic groups? Since Durkheim's seminal study over 100 years ago, the potential relationship between work and suicide has been acknowledged. But research on this relationship is limited, especially among American Indian and Alaska Native communities. Research on work and suicide has traditionally focused on three main areas: suicide that occurs at the workplace, which often explores access to lethal means at work; rates of suicide by occupation, which often explores characteristics of different occupations that might contribute to elevated rates; and the relationship between unemployment and suicide, which may be the most relevant to this presentation given the high unemployment rates in these communities. However, simply increasing the number of jobs is not enough. Increasing reliance on temporary employment agencies and other contingent employment arrangements has led to growing recognition that not all jobs are created equal. Estimates suggest that nearly 1 in 5 U.S. workers are in non-standard job arrangements. Rates are even higher for racial and ethnic minority populations, who are often concentrated in the most exploitative contingent jobs. As Alex mentioned earlier, job quality, or how jobs are structured, is an important variable when understanding the relationship between work and suicide. Recent research suggests that a lack of supervisor support and job insecurity are linked to suicidality. Therefore, in addition to job availability, it is important to consider factors such as job stability, compensation, and social support when evaluating the relationship between suicide and work. Like schools, the workplace offers a venue for broad prevention and population health interventions. Under the mental health model, the workplace can be used to train employees to recognize the warning signs and risks for suicide and provide them with access to resources, particularly in high-risk occupations. Interventions can also be implemented to reduce access to lethal means at work. Under the public health model, increasing the number and quality of jobs that can serve as a prevention strategy by increasing economic security, self-esteem, and social connectedness. This is easier said than done, as public health professionals generally don't control or engage with local development projects. However, seeing work as a social determinant of health provides public health officials a lens through which to evaluate development projects, the jobs they propose to create, and their potential impact on the community's health. Jobs are a shared concern among public health officials and other stakeholders, such as tribal governments and tribal employment rights organizations, who can often influence, either through negotiation, legislation, or regulation, how jobs are structured so that they better contribute to the health of the community. Improving our understanding of the relationship between work and suicide in American Indian Alaska Native communities will require better data on work-related variables by public health researchers and better collection of data related to race and ethnicity by occupational health researchers. For example, the National Academy's Consensus Report on Occupational Health Surveillance recommends that all HHS surveys begin to collect data on industry and occupation. Improving access to good jobs could form part of a more holistic suicide prevention efforts for American Indian and Alaska Native youth. There should be greater recognition of work as an intervention site to improve access to resources and improve other social determinants of health, like income, housing, and social connectedness. Work can be understood as a primary vehicle for responding to the Surgeon General's call to action on community health and prosperity. Discussions of job quality, not just job quantity, could help public health professionals engage more established initiatives on such as sustainable development and corporate responsibility that are increasingly influencing development projects and how businesses and jobs are structured. This engagement could not only help leverage technical resources, political support, and funding for suicide prevention, but could help ensure that these development projects and the jobs they create are designed to contribute to healthier communities. In conclusion, work's potential as an intervention site to provide access to resources and improve social determinants of health is a powerful yet underutilized tool in addressing health inequities, like the elevated rates of suicide among American Indian and Alaska Native youth. Thank you.
As promised, we have some resources available on preventing suicides and suicidal behavior. I'm going to scroll through them in the interest of time to save for the question and answers. These resources and the slides will be posted at our website in about 2 days. And now I'd like to open it up to the Q&A. You can do it from there.
And I know we had received some questions through our mailbox, and I think we'll start off with those, and then we'll go to those who are in the audience.
At cdc.gov or post in the Facebook live stream. We have a question from or comment from Avril that states that she's read somewhere that suicide is contagious. Is the isolated community of the indigenous population exacerbating suicides?
I don't know, Dr. Manson or Dr. Laufenbrois?
I think you could say that every culture has gifts and burdens. And one of the most wonderful gifts about many American Indian and Alaska Native communities is the closeness of the extended family. But we also know that suicide is contagious, and therefore it's a burden as well, because when someone dies, it affects most everyone in the community, or many in the community. Someone can jump off an overpass in the Bay Area, and it's just a clip in the newspaper, which is out where I live. So I think that's what I would say to that. Mm-hmm.
Yes.
Yeah, Dr. Laframboise, thank you so much for the work that you've been doing. You described the invitation into the school system after events had occurred after the cluster of 5 children. I wonder if you could comment on the value or the openness to introducing the curriculum in schools that haven't experienced a student suicide, whether there's sort of a different track for pure prevention versus the interventions after events that are locally known.
Well, I think certainly when there has been, a death or deaths by suicide, people are much more eager to embrace an intervention. However, I think that the behavior, if you count ideation as well as gestures, is so prevalent now that I think almost every parent and teacher or community member are very responsive and ready to embrace it. The difficulty about getting this into the school system is really because of the emphasis on making grade and academic content, and educators are reluctant to give up time. But then it's very difficult for children to learn when they're all in grief over their recent friend's death by suicide. So I think it's a mixed bag. I think people that are more forward-thinking and administrators that think about the whole child embrace it slowly. I mean, I wouldn't even say slowly, reluctantly. They know they need to do it, and will do it. But I think it takes that for people to be open to this kind of intervention. Honestly, this kind of intervention.
I'll add one other thing too, along with what Dr. Laframboise said, is, oftentimes principals or superintendents over school districts, if they're exposed to the data or made aware of the data, when we look at surveys like the Youth Risk Behavior Survey, and I know the Bureau of Indian Education, Bureau of Indian Affairs has also done some surveys, and you look at the questions that ask about, have you seriously considered suicide in the past 12 months? Have you made an attempt? Have you made an attempt that required medical attention? Have you made a suicide plan? That oftentimes you will see that there's a high percentage of adolescents in high schools or in middle schools that are self-reporting that they've thought about it. So while the deaths may not have occurred in those particular communities, you see a number of the youth that are thinking about it or have made attempts in which they didn't go and tell anybody. So oftentimes that burden is there in the community, and it's just a matter of making those that are in leadership aware of what that problem is so that they can respond to it and know kind of what the things are that are appropriate. I think we've got one person there, and others, will make sure that you use your microphone when you go to the back room.
And thanks for highlighting schools and workplaces as a place to make interventions. I'm wondering if you could talk a bit more about what the intervention looks like for providers. Are there gaps in training providers to identify or intervene? Do we feel like providers know what to do? And is that a gap area for us to think about it from the health system perspective?
Actually, I think Dr. Manson could probably be in the best place to answer that one.
That's a great question. So that, for example, in the Southcentral Foundation SBIRT initiative, you may have seen that I think there was 27% of the individuals who were screened over that period of time were identified at high risk and then referred to the management processes. We went to the electronic health record of that particular healthcare system and discovered that of that 27% of 58,000 individuals, 91% had no note in the health record about the risk of suicide. So it's not surprising then that the providers themselves were ill-equipped to either detect, much less manage those at risk. So a part of this process in building it in a team fashion is that these behavioral health consultants, through weekly case conferencing, the debriefing around individuals at particularly high risk who required crisis intervention, led to a bi-directional educational process among all of the staff, from receptionists through the primary care provider team themselves. And I think that really is what speaks to the widespread success of that intervention in that setting and the others that I've had the privilege of working in.
I'll add on one other thing to that too. I agree with what Dr. Mans had said. One of the initiatives that has been started around the country is what's called Zero Suicide. That was based on an intervention that was done in the Henry Ford Maintenance Organization in Detroit, and then also Magellan out in Phoenix, in which part of what they did was, just as he was describing, educating every provider within their healthcare network about, if there's an individual at risk, you're making sure that the rheumatologist, that the pulmonologist, that the pediatrician, they all know that this person the continuity of care needs to be maintained, and that we try to make sure that this person is receiving the kind of services that they need. And they were able to drop their suicides within their patient population to almost zero. So it is a matter of educating those within the network, the providers, as well as patients, as well as family members, about what's going on, and to make sure that things are being followed up on. I think there was a question here first. Oh, we got another one from the mailbox, and then we'll come back here.
Thank you. Christina on Facebook. Does the CDC have research on the effectiveness of postvention efforts in the AIAN communities after a suicide or a string of suicide? Here in Alaska, we had 16 suicides within a 2-week period in one small community of Hooper Bay, and it pointed to the need to respond quickly after suicide. Wondering if there is research out there and support for postvention work.
There has been some work done in that area, but I think in terms of the evaluation of it, that's still pretty lacking. But there have been some protocols developed that have tried to look at postvention. And basically what postvention is after there's been a death, what are the way that you bring in services? How do you focus on particular populations, those who are closest to the person that died? How do schools address a particular death? How do occupations address a particular death? So there are protocols for doing that. The evaluation of how well they work, I think many of them are based on strong theory and the best available evidence, but the strong evaluation is probably lacking. I'm not sure if anybody else wants to also address that.
Alaska actually is probably the most advanced in Indian country in terms of the acquisition around data around in regard to this, as well as related questions. What's the most predictive risk factor for suicide? It's past attempt. So it makes absolute sense, not only in terms of predictive validity of one's efforts, but the cost and the efficiency of programming to ensure that the kinds of services that are necessary to reduce the likelihood of subsequent attempt focus on such individuals. And there are a number of examples. The Native Connections program, I think, was cited among the materials. And there's several Alaska Native communities that have been focusing on postvention intervention with those who've attempted. So it's a very well considered approach.
Okay. Let me go to here. If you had a question here, I know we've only got about a couple minutes left, so we might have time for maybe one more. Go ahead. Okay. How about right here?
Well, can I ask two questions?
Make them fast.
Okay. Want to be sense of time. Commander Crosby, you mentioned that there's more young males that complete suicide, but there's more young women that attempt. Can you go more detail about that?
Generally, when we've looked at mortality as well as morbidity, we see that males die of suicide much more than females. There's a number of different factors that play a role in that. Some of it has to do with a choice of method. Some of it has to do with, the lethality. Some of it has to do with other kinds of things that happen in terms of socialization and some of the other risk factors. Whereas when you look at morbidity, non-fatal self-inflicted injury, that females report more. And then when you look at emergency department records as well as hospitalizations, you see females have higher rates of non-fatal suicidal behavior. So there are a number of different factors that play a role in that, but at least in terms of the demographics, that's kind of plays out.
Okay. Another question I had was for you, Dr. Love-Royce. You mentioned two terms that I'm interested in. You mentioned public collective esteem.
Yes.
And then you mentioned disturbed eating. Can you?
I don't remember mentioning disturbed eating.
It was on one of your slides.
Oh, on one of the slides.
Yeah.
Okay. On one of the slides, I was talking about the factors, that are the issues, the problems that might be somewhat different at different age groups. And certainly there are, eating disorders in all communities, and there are eating disorders in Native communities, right? Okay. So it's just, thinking about disturbed eating as one of the beginnings of risk, or you could say even, I guess theoretically, you could say self-injury to some extent. So it's a matter of looking at the problems that people focus on or are dealing with and how they progress and become more challenging to work with at different age groups. That was that one. In terms of public collective esteem, that is a term that I believe was coined by Robert Sellers in his work on racial ethnic identity, basically, African American racial identity, but it's widely used, and it is a perception of what other groups think about my ethnic racial group, what others think of my group. So in this case, the situation was that people felt more positive about what they think other people think of my group.
I know we are. This is probably the last one, and I think we're out of time.
Yes, it is. From Jenny on Facebook. Are committees working to implement job growth or bringing in business to these communities? Maybe incentives?
I don't know. Mike, if you want to answer that one.
What was the question exactly, though?
Are committees working to implement job growth or bringing in business to these communities? Maybe incentives?
Yeah, I think the idea would be, how do you, when we talk about job growth, like I was saying, it's more than just creating jobs, but it's also engaging with the folks creating those jobs on what type of jobs they're going to be. Are these permanent? What are they, permanent or contingent work? Is there going to be good? What are the benefits? What are the salaries? What are the time constraints? All of these things, to see how the job not only brings an economic income to folks, but also is structured in a way that contributes to the overall health of the individual and the community.
This is actually very active dialogue in tribal communities, because one of the challenges we face in terms of establishing and sustaining tribal business enterprises is not recapitulating the negative and adverse consequences of other corporate models. And I think there's some wonderful examples out there that suggest that. And we see associated with those examples are an array of kinds of supportive services that are pretty remarkable in how they mobilize the necessary resources to tribal employees who may be at risk of the problems that we've been talking about today.
Thank you. That's all we have time for. Would please join me in a round of applause for the excellent presentation from the speakers. We'll see you in the next Public Health Grand Rounds.